surgical abdomen, but remember, not all acute abdomens require surgery, and therefore, we have moved away from the idea of calling it a surgical abdomen. We now call it just an acute abdomen and try to make a diagnosis so that we can make a plan for the way forward. A quick review of what is pain. Pain is just a sensation caused by noxious stimuli, but there's a big difference between visceral pain and somatic pain. Someone pinches you on your left forearm. All of you will be saying, this chap is pinching me on the left forearm. The chap with appendicitis will tell you, I have appendicitis. Please mute those of you who are not muted. And visceral pain tends to be very poorly localized and tends to be diffuse. Somatic pain, on the other hand, is very well localized. Now, you must still remember that much as visceral pain is poorly localized and diffuse, that the concept of referred pain still operates even with visceral, such that foregut structures, that is everything up to the mid, basically ilium, the pain tends to be higher. Then mid-gut structures tend to give you central abdominal. That's everything up to almost the whole colon. And then hindgut structures will give you pain, which tends to be back and in the pelvic. Now we group the causes of acute abdomen into huge general categories. Maybe inflammatory, which is either caused by an infection or spillage of chemical. And one of the chemicals which can cause abdomen is blood is not normally found within the peritoneal cavity. It's very irritating. Why people with ruptured ectopic present with very severe abdominal pain. Then there may be a mechanical problem, usually intestinal obstruction or a twisted ovarian cyst, whatever. There may also be a neoplasm, may either be benign or malignant. Vascular issues, especially occlusion of mesenteric veins, causes pain. Then obs and gyn, all of them together, and medical issues can also cause abdomen. If you forget everything else we are going to talk about today, just remember this. The patient with an acute abdomen needs a very quick, focused, but thorough history. Also, I need a very thorough physical examination. And then the labs and the imaging are usually guided by what you find. If I find you are sitting with a patient with very severe abdominal pain in accident and emergency, or in the emergency department, and I find that half your history is about drawing a family tree, is a problem. If I find that you are still finding out how many jobs they have had over the last 5 years, then it also tells us that you are not focused. But we want a history which focuses on this abdominal more than anything else. What I have found, and I am in no way saying that this is a must, you can use the ample, the samples, whatever other mnemonic works for you. But always aim at getting everything sorted out within a 5-minute period. So what I use is this OPQRST. It works because it's very easy. You just ask the patient, when did it start? That's all. What caused it? That's provocation. How has it been from when it started up to now? Progression. Then quality of pain. Is it stabbing in nature? Is it constant? Is it dull? Is it throbbing? That's all you ask. Then where is it? Where does it radiate to? Then How severe is it? And timing. Did it come after a meal? Did it come after a drinking binge? Did it come after going to the loo? And all those things. Then things that relieve it, things that make it worse, ask about all those. Always with severe abdominal pain, you must ask about vomiting, bowel function, and here you have to be very specific. You ask the patient, when was the last time you had a long call? Are you able to? How is the stool? Is it hard? Is it soft? Is it diarrheal stool? About bleeding. Bleeding can be in 3 directions. Patient might have rectal bleeding. Patient might have hematemesis. Patient may have urethral or vaginal bleeding. Ask about all those. Then ask when they last felt well, when they last ate a normal meal, what has happened to the appetite. In all females of reproductive age, ask about the last normal menstrual. Seek out and be very clear about possibility of pregnancy. Okay, and if there is pregnancy, how far along is it? Ask about urine also. Patients with some conditions have recurrent episodes of abdominal. For example, gallstone disease or urinary stone. And they will always be able to tell you, I've had this problem before, this is what was happened, this is how it was managed, and this is the further management, and unfortunately I have not come back, why I am here. Ask whether they've had surgery before. Ask about a history of peptic ulcer disease, the disease, gallstone disease, stone disease. Always ask about alcohol use. You have to be tactful at times. You don't want to ask somebody in front of his 15 relatives how much alcohol they will lie. So you make sure you catch your patient alone and they will be more honest with you. Medicines, especially steroids, non-steroidal anti-inflammatory drugs, and now we've added to the older, the AZT and so on, the older ARVs, they also tend problem. Contraceptive use, sexual history, and then you ask about fever. Do not aim at being 100% sure as you take this history that, oh, this is an appendix, oh, this is a twisted ovarian cyst, or this is intestinal obstruction. What you want is just to find a general area of saying this is probably it's right flank, probably appendix, but maybe kidney stone, maybe an ovarian cyst, whatever. Pain in the upper abdomen, you obviously are looking at ulcer disease, pancreatitis, abdomen, diverticulitis, ovarian cyst, twisted ovarian cyst, ovarian mass. In the mid-abdomen, most often it's gastroenteritis, normal, usual gastroenteritis. If you are thinking surgically, maybe migratory pattern of the pain, what spells out most of it, in the sense that if the patient tells you that the pain started as a localized pain and then has now affected the whole abdomen, then you know for sure you're dealing with it. Appendicular pain migrates in a predictable manner from the epigastrium to the periumbilical region to the right lower quadrant. Just for you to remember these quadrants. Good. When you go to the physical exam, always remember to look for a hand. Palpate first, look for rigidity and guarding, look for hyperesthesia, always perform a rectal exam, and sometimes you may have to perform a vaginal exam. Now, those of you who want to pass cuts in terms of MCQs, you must know each of these signs. One, when it is positive, and two, how to elicit or obturator, psoas, Prof signs, Allen sign, Greitana sign, and Mark sign. The concept of referred pain is important for us to understand. Pain from an inflamed gallbladder will go to the right scapula on the lower side of the back. Pain from appendicitis, if it is early, will actually be periumbilical. Pain from pancreatitis is always at the back center of the abdomen. Patient tells you it is at the epigastrium, but the back, and is improved by the patient leaning forward. Rectal disease, the pain goes to the lower back. Now, kidney stone disease and ureteric stones. Pain usually goes either to the scrotum or to the labia on the same side as the problem. And obviously, irritation of the diaphragm, the patient will have pain at the tip of the shoulder of the same side. The labs, it depends on what you are looking for, but there are some specific things you will do for almost all patients. Total blood count, analysis, and rare electrolytes, creatinine. But that doesn't mean you forget all these other things. Will have been binging and they have a severe abdominal pain. Yes, you can make sure that it is not pancreatitis by asking for an amylase and a lipase. Blood gas analysis if your patient is very sick. Beta HCG assays if you are still suffering pregnancy, despite a negative urine pregnancy test. Now, on imaging, you choose the one that will answer your question. So there are no hard and fast rules here. Some patients with an ultrasound, you have fixed their problem, you can plan management. Some patients, despite everything up to CT scan, you still haven't figured out, then you start asking for additional study. When you are formulating your differentials, please always start with very broad categories. This is in your mind. This is a mind thing. You don't write this down. You look at a patient and you're like, looks like obstruction, looks like inflammation, looks like pressure, looks like good. When we talk about ischemia and perforation, in acute mesenteric ischemia, the pain is central abdomen and it is so severe the patient stops walking around. In chronic mesenteric ischemia, typically the patient is a smoker, already has peripheral vascular disease, and now on top of their legs being painful or being amputated toes and so on, they have this pain in the abdomen which comes, goes, comes, goes. Colitis also may present with abdominal pain. Obviously, any inflammation, obstruction, or ischemic process will progress. Now, I have put this at the very bottom, this ruptured abdominal aortic aneurysm, not because it is common, but because it's an extremely rare fatal condition which progresses very rapidly. So when you find you can't make up your mind, make sure you do investigations to rule out ruptured triple. Now, how do you make a decision to operate or to admit? Patients who have peritonitis, in other words, they have generalized tenderness with guarding, then there is nothing to talk about. Must be patients with severe and unrelenting pain must be unstable patients. Now, unstable is a very simple word to say, but difficult concept. Patients who are unable to sustain their own circulation or who seem to be deteriorating despite your best efforts, are the unstable patients. Then patients whom you suspect is strangulation or bowel ischemia. Obviously, if there is gas in the peritoneum, then that tells you there's already a perforation. complete or a high grade obstruction is also another indication. There are situations where it might be very difficult for you, but patient is very sick. Patients who have had a stroke or a spinal cord injury might be difficult. Patients who are under the influence of drugs or alcohol, and patients who have had previous surgery. The severity of disease can also be masked by steroid use, immunosuppressant use, and pregnancy. So you have to be careful with this lot. Now, when you look at this CT scan, you can all see the appendix, I hope. That solid white arrow in the middle. That solid white arrow is showing a structure which is in the cecum. Probably this one is showing us acute pancreatitis. Just one person to answer. Can you see my pointer? Can anyone see my cursor?
Yes.
Yes.
Good. Let's start with what is normal. This is either L1 or L2, most probably L1. Okay. This is the aorta. This is the celiac. So far we are together, I hope. And this whitish, a well-perfused pancreas. But when you look around it, there is that grayish area. That is the inflammatory process around. So this is a patient with acute. Now, all your books have this thing. So don't harass yourself copying. But when you look at surgical causes, most common cause of acute abdomen is actually followed by acute colitis, then intestinal obstruction, biliary colic, ureteric colic, then acute urinary retention. Then in our setup, PAF-DU, and then pancreatitis, then diverticulitis. So those are the things you must have at your fingertips, know how they present. Then the ones that are caused by the medical conditions that cause acute abdomen can be simple things, gastritis, acute gastroenteritis, herpes zoster. Before the rash appears, the pain is there before the rash appears. Urinary tract infection, sickle cell disease, diabetes mellitus, Addisonian crisis, and then spherocytosis. There are some patients with a basal pneumonia or with a basal pulmonary embolism will present not with chest issues, but with abdominal. So you have to. Sometimes pericarditis or a myocardial infarction can present instead of classic pain in the left chest, have pain in the abdomen. So you have to be a bit on that one. Obviously, the other things I think about the and gynae issues, ectopic pregnancy, pelvic inflammatory, salpingitis, metal smash, endometriosis, dysmenorrhea, fibroid degeneration, bleeding into a fibroid, bleeding into an ovarian cyst, torsion of an ovarian